Okay, everybody, you ready? All good. Hi, everyone. Welcome to Jett Foundation's Rochester, New York Family Workshop. We're thrilled to have you all here. My name's Mara Carroll. I'm the Director of Development here at Jett Foundation. We have a packed agenda today. As you can see, it's 2 pages long, which is not usual for us, but we're super excited to have our friends from University of Rochester here to speak. Several clinicians that are speaking today. Thank you to our industry partners that are here that make this possible. And of course, thank you for the families that are here. We're looking forward to getting to know all of you today. So to share a little bit about our agenda, so I'm just going to give a little brief overview of Jett Foundation and our programs. We have a little bit of a change in our afternoon perspectives, but I am going to be introducing Ken Manning from Suneel's Light, who's going to share a little bit after I speak this morning. So I think that is mostly our agenda for today. So next, I just wanted to share a little bit about Jett Foundation's community webinar series. Oh, I did want to introduce it for anybody that hasn't met yet. Gabby Costa, who is here from Jett Foundation, and then Julie is here as well. Where did she go? I'm sure you all registered with her first. So our community webinar series, so this is a wonderful tool that Jett Foundation offers. We have online webinars pretty much each month. Some of our industry partners each will do a presentation of their clinical trials or their programs, but we also have some other great topics that have been very popular with our families, like financial autonomy, clinical trials, accessibility and adaptive tools. So we do have some upcoming webinars, so if you're not currently receiving our emails and updates, please do. One of our most pillar programs that I feel like Jett Foundation is most known for is our Jett Giving Fund. So that has 3 branches of assistance for our families. So there's the Accessible Vehicle Fund that does help families that are in need of safe transportation. That's a once a year open application. It is actually open right now. So if you know of any families that are struggling, they can apply to that. I think it's through the month of December. We did gift 16 vehicles to families this past year. The emergency fund is really what it sounds like. It is to help families that are struggling, maybe a recent loss of a job or a hospital stay, and families that are really needing quick turnaround help, whether it's food assistance or rent, utilities. Our emergency fund, you can submit applications and we can sometimes turn it around in 24 hours if it's a true emergency. And then equipment assistance as well for equipment that is not covered by insurance. Sometimes the copay itself can be too much for some of our families, so that is available as well. And really, since we opened these branches since 2017, we've gifted $5.5 million to the community, and that's a lot to do with our partners and community support. Thank you. Next, I just wanted to mention Camp Promise. That's another program that I think we are well known for. So we have 3 branches of our Camp Promise program. So we have 7 camps across the country. Some of them are 13 years and older. Our retreats are for 18 years and older. And then we have our virtual weekend and Camp Promise Connect, which really is year-round. Once a month, we have trivia nights and lots of activities throughout the year online, as well as our on-the-ground camps. And this past year, we served about 78 campers through our virtual program and 150 through our on-the-ground camps. Now I can't hold this and this. Here we go. And our family support group. So this is a program that we have 2 coordinators, our social worker and one of our ambassadors run our family support group. So that's every other Monday night. It's an online parent support group that is really just to build connection with families to, feel not so alone and to gain great resources and information. And stay connected. So I think you're all here, so you're probably connected, but these are lots of different ways that you can follow us on Facebook, on Instagram, Twitter, LinkedIn, and so visit us. And you can always visit us. Our main offices are in Norwell, Massachusetts. If you're ever in that area, please come and say hi. Okay, so I think that is all for my introduction, and I did want to invite our friend Ken Manning from Suneel's Light, a local nonprofit that was just going to share a few words about Suneel's Light and a great partnership program they have with us.
Thank you, Maura. It's good to meet all of you this morning. My name's Ken Manning. I'm the stepfather of Suneel Ram, who has Duchenne muscular dystrophy. Suneel's 28 now, and he graduated from college. He's doing some graduate studies at the moment. His mom, Dr. Gulati, is seeing patients this morning and couldn't be here, so she asked if I would attend in her place. Our president was, Tom Mahar was scheduled to come here, but he's been stranded in Florida with some of the flight delays, so forgive me if I'm a stand-in. I'll try and do okay, so thank you. Lived with raising a young man with Duchenne muscular dystrophy over the past 25 years or so, and there are a lot more opportunities these days in large measure due to the efforts of the Jett Foundation and other organizations like Suneel's Light that have kind of pitched in and try to do what we can to try and further the therapies and ultimately a cure for Duchenne muscular dystrophy. In the past, I remember meeting with Christine McSherry when she started Jett Foundation. I think Neera and I were up in her home, and how far the organization has come since then. We've partnered with Jett on a number of occasions. I think Maura was reminding me, I think it was probably 5-6 years ago in Rochester here where we did kind of a joint program. And we've collaborated since that time. And the one program that Maura mentioned, the emergency program, is something we've helped fund. There's money available to the families for emergency needs, and as a Duchenne family member, it's hard sometimes with all the burdens you have to meet all the needs of a boy with Duchenne muscular dystrophy. It's hard to find time even to look around and see what's there. If you do, though, their website, if you can get on the website, if you're in stress and you need emergency funding, there's money available to you. Please take a look. It's there for the asking. I'm looking around some of the sponsors. I should mention over the years, Neera and I have traveled in the earlier days when there were very few therapies that looked promising. I remember meeting with the NS Pharma people. I think we were in Kyoto at the time with some of their researchers. We've been to England, and when AVI was around, formerly now Sarepta, with their clinical trials, some of which went well and some of which didn't in those days. But ultimately, after testifying in DC in favor of moving some of these drugs, the earlier drugs, to market and getting in a very controversial proceedings, the drugs to market, there's so much more available to the boys now than there was then. And with the sponsors you have here today, there's more therapies and clinical trials available than perhaps ever before. So I think you're in the right place. Jett Foundation will fill you in ways that others can't. And I hope you are attentive, and I hope you participate and support what they're doing. I do think that one of the things that Suneel took advantage of was Camp Promise. It really is a wonderful opportunity for the boys to get together. It provides a measure of support from their peers that you really can't find anywhere else. So if you have the opportunity to engage in that, it's a wonderful experience as well. So I'll be around this morning if you have any questions. There's flyers that we put out that Jett was nice enough to print off for us and make available to you. So if you're in distress and you need help, there's a place for some of that help. So please feel free. Taking questions? I'll be around for a while. You know how to find me. Maura, back to you.
Thanks so much, Ken. And so let's get started. So our first presentation will be with Deborah from the University of Rochester School of Nursing.
I want to say good morning, and thanks for you all coming and sharing your Saturday with us, and thanks to the Jett Foundation for having us here today. I'm going to talk a little bit about the benefits of multidisciplinary care. I have slides, but I feel like I really don't need them, but So we'll start with a definition of what multidisciplinary care is. It's a collaborative approach, and that's what I truly feel. We have many members of our team sitting over at this table, and it is really a collaborative approach. Every single person on our team brings something different to the table and is able to assess our boys and young men with Duchenne. So we work together to provide comprehensive and coordinated care for our patients. It takes a village, and I borrowed this slide from Dr. Cefaloni. She says this all the time. We have at the center the individual with DMD and their family, of course, but there's so many other aspects to care, and it can be overwhelming, it can be confusing, it can be all of those things, and it may be one discipline is more needed than others at certain times. But we all work together to help as the disease progresses and as our boys get older. The multidisciplinary team it usually has a neuromuscular physician or a rehab physician at the center, a clinic coordinator, Joan is ours, physical therapist, we have one of our physical therapists here who you're going to be hearing from, a genetic counselor who couldn't be here today. We have one of our pulmonologists here who sees both pediatric and adult patients, which is a little bit unique. Cardiology, we have one of our pediatric cardiologists here. We have social worker, and then kind of in the behind the scenes that you won't see, and it has become so important with the new therapies that have come forward, is our team of pharmacists and prior authorization team. They work very hard behind the scenes to bring these therapies to your boys and help us make sure that we have the right documentation and that you get the medication in a timely manner, and that they help with appeals, they help with prior auths, they really are the engine behind the team. And then we have endocrinology, palliative and supportive care, which has been relatively a new addition to our clinic, where our supportive care physician tries to meet with every family when they come to clinic. And then orthopedics for the musculoskeletal needs that our boys have. There's challenges in delivering multidisciplinary care. Sometimes it's like herding cats, right? You have a full schedule on a busy day. What, Joan, we see maybe 10, 12 boys, young men with Duchenne. We have a morning session and an afternoon session. We have a whiteboard that we try to keep track of things, but it's organized/disorganized chaos. But the benefit is that you get to make one trip, and you get to see, at least at our clinic, your neuromuscular specialist, a social worker, a physical therapist, a pulmonologist, the supportive care person, social worker. And then we have very close contact with the other disciplines that we refer out to, cardiology and orthopedics. And like I said earlier, we all bring something different to the table. One person will go in and think they know the whole story, and then we send the physical therapist in, and they'll come back and say, hey, did you know this? Or so it really is a team approach, but we recognize that it's hard on the families. Many of you travel a long distance to come to these centers. It can be long, it can be tiring, it can be costly. And then we're unique at University of Rochester in that we don't transition for our adult patients for the neuromuscular care, but we do for our other disciplines. And we help to coordinate that for families. Again, we do have a benefit, and you'll hear from Dr. Kroll later. She was trained in med peds, so she is very familiar with the pediatric pulmonary needs, but then can see our adults as well. And then there's special subgroups. I'm not going to touch a lot on this, but newborn screening will be coming, and what do we do with positives with that? Our female carriers, and then, as you know, Duchenne muscular dystrophy is a spectrum, so we have those the Becker patients. And then I'm going to keep this short and sweet. And if you can take one thing away from this presentation, is the importance of primary care. We hear a lot of times that our families don't have pediatricians or primary care physicians. And it's an important and integral part of your child's care. You don't need to have a primary care or a pediatrician that knows about Duchenne. We've got that piece, but they have to be able to listen to you and to be willing to reach out to us if there's questions, and just someone you feel comfortable with. And that's it.
Next up, we'll have Kate, physical therapist at University of Rochester. Nope. Or Nicole. Did you want Nicole to come first? Yes, it's only me. Oh.
Thank you. Yeah, absolutely. This one?
Yep.
Okay, perfect. Okay. We're good? Okay, awesome. So, hi everyone, I'm Nicole. I am one of the physical therapists with the neuromuscular team at Rochester, and as Deb said, we're excited to be here, and thank you for all showing up, and thank you for the Jett Foundation for having us. So I wanted to start off very briefly by just talking about who physical therapists are. So physical therapists are movement experts who work to optimize quality of life through hands-on care, patient education, and prescribed movement. And so in Duchenne muscular dystrophy, physical therapists serve multiple roles. We're going to evaluate strength and function. We can also prescribe and then monitor treatment plans. The services can be provided in a bunch of different settings, including the outpatient setting, at school, or at home. And the ultimate goal is to help maximize functional abilities and prevent secondary complications like contractures or disuse weakness. So in terms of what an evaluation is going to look like, a comprehensive evaluation by a physical therapist is used to help us identify a person's current abilities as well as their limitations in order to create an individualized treatment plan. And so evaluations may include multiple things. So gathering information about participation in daily activities, looking at measuring range of motion, assessing strength and function, and also exploring quality of life. All aspects that are helpful for us to be able to create a treatment plan. And so treatment plans may include activities like play-based activities as the child is younger, moving into aerobic exercise, resistance exercise, also range of motion activities, bracing recommendations, and then assistive device prescription. So I'm going to talk about kind of each of these individually now and provide a little bit of supporting research to support some of the exercise. So first, play-based activities, right? These are simply designed to improve motor skills, balance, body awareness, and coordination. And so play-based activities can be really effective method to engage young children in meaningful play, and they can help to promote gross motor milestone development. And play can be continued to be incorporated as the child ages, and certain activities may include utilizing obstacle courses, ball games like catching, throwing, or kicking, animal walks, bear crawling, or frog jumps can be very helpful. Utilizing equipment like balance boards or wobble cushions, and then also swings or adaptive bicycles. Okay, so aerobic and resistance exercise. I want to talk through just 3 studies briefly just to kind of set the stage. So this study in 2013 looked at assisted bicycle training and how it delays functional deterioration in boys with Duchenne muscular dystrophy. Now, I won't go into too much detail because I don't want to take up too much time, but ultimately, this is what the trainer looked like. It was for the legs and the arms. And the study provides evidence that assisted arm and leg cycling is both feasible and safe for boys with Duchenne, regardless of their ambulatory status, and that the results suggest that consistent, low-intensity dynamic exercise can help maintain function and delay secondary decline that often results from disuse. Let's see, this next study was conducted in 2021 and looked at the safety, feasibility, and efficacy of strengthening exercise in Duchenne muscular dystrophy. And this is what the piece of equipment looked like, okay? And same thing, I won't go into too much detail, but the second part of the study looked at isometric strengthening training. And it provided evidence that a 12-week moderate intensity isometric strengthening program was both safe and feasible, and that the program demonstrated the potential ability to improve strength and function in ambulatory boys with Duchenne muscular dystrophy. And then the last study was actually a comprehensive literature review titled Updates on Exercise in Persons with Muscle Disease. And so this was conducted in 2025 and published in January of this year. And so it provides an excellent overview of exercise studies in Duchenne and Becker muscular dystrophy over the past 10 years. And they had some wonderful conclusions here. So first, that aerobic and strength training can improve functional abilities, muscle strength, and mobility in patients with both Duchenne and Becker. That resistance training was also effective in improving muscle strength, functional tests, and ambulation. And then also combining exercises with interactive forms of therapy may lead to improved outcomes. Okay, so that was kind of the recap on literature for that aspect. And then I also just wanted to briefly touch upon aquatic exercise, because aquatic exercise is a recommended mode of aerobic exercise. And so there's actually not much literature out there, but it does appear to support the safety and effectiveness of aquatic exercise. They've seen improvements in the 6-minute walk test and also enhanced function with the 10-meter walk-run test. And then briefly, just some benefits of aquatic exercise. So buoyancy, right? This can help support the body and reduce pressure on joints. It can also help with muscle strengthening because water gives light resistance. Respiratory health, it's a great environment to do breathing type activities that can help support breath control. And then lastly, range of motion and mobility can be performed in the water. Okay, so we talked about a lot of literature, so I just wanted to highlight a few key takeaways. So really, emerging literature supports that these forms of exercise are safe and effective in individuals with Duchenne, and ultimately leading us to determine that it really should be integrated into routine neuromuscular care, but the programs need to be individualized and monitored to make sure that we are implementing safe and effective methods for each person's unique needs and limitations. Okay. So I won't go into this in too much detail, but basically physical therapists can use the FIT principle to determine what types of exercise and at what frequency we want to prescribe them. So basically we're looking at frequency, intensity, time, and type. And from that review that I mentioned a little bit ago, they provided a nice kind of overview, again, in all muscle diseases, and then I adapted it to be related to Duchenne. But basically we're looking at low to moderate intensity exercise. We want warm-ups and cool-downs with exercise periods lasting about 30 minutes, and then a variety of different options, right? And on the screen right there, you can see an adaptive tricycle, which is a great form of exercise. Okay, so just a few more things. As I introduced earlier, range of motion is also really important.
Can you go back to the last screen? You're
Yes, of course. Perfect. Okay. So stretching is also very important, okay? So it's recommended that we do some form of stretching about 4 to 6 times per week. And really it's the consistency, so the daily aspect that's more important than the amount of time you spend per day doing stretching. And then just to highlight some areas that we want to focus on, so for the lower body, looking at the ankles, the knees, and the hips. And this is important because the ankle plantar flexors, knee flexors, hip flexors, and hip abductors are the ones that tend to get tight and contracted. And then for the upper body, looking at stretching the hands, the wrists, and the forearms, and same thing, because the finger flexors, wrist flexors, and forearm pronators are the ones that tend to get tight. And then lastly, bracing recommendations and assistive device prescriptions. So bracing can really help complement stretching routines. And so there's a few different bracing types that we can consider. So first, simply just shoe inserts. So these can help support foot posture during walking. Supramalleolar orthotics, so these can actually provide a little bit more stability and help support the foot and the ankle joint while walking. And then ankle foot orthotics, so we don't typically recommend these for any daytime walking in ambulatory boys because it can reduce their ability to utilize compensatory strategies, okay? But we can use them for nighttime stretching and also daytime stretching and positioning once non-ambulatory. And then lastly, a few assistive devices. Standers can be very helpful promoting upright positioning once weight bearing and standing become difficult. And then wheelchairs, any type, manual with power assist, or power wheelchairs can help promote mobility and independence once they are needed. So the last piece of the physical therapy care is really monitoring. So how are we making sure that our plans are appropriate? And then also, how are we making sure that either some progress or at least maintenance of strength and function is occurring? So this may include some sort of re-measuring of range of motion or reassessment of strength and function. And I also talked very, very briefly when the slide about the FIT principle came up about monitoring during sessions. So that could be looking at utilizing the talk test or heart rate or talking about pain and fatigue with the kiddos. Then there's also specialized functional assessments, which you guys, I'm sure, are aware of. The North Star Ambulatory Assessment can be very helpful, as well as the Performance of Upper Limb module. And this also includes time function tests like the 6-minute walk test, the time to climb 4 stairs, the 10-meter walk run, and the time to rise from the floor. And so specifically, those specialized functional measures can really help us to predict functional changes in a clinical setting. There are certain cutoffs that we know as clinicians that we can use to understand when someone may need more supportive ambulatory assistive devices. So it's important to use the same functional measures to track changes over time. And also we recommend conducting these probably around the every 6-month mark. And then my last 2 slides, I just wanted to talk about where we are and kind of where we're going. And so from that review that I talked about previously, there was just a nice quote that I wanted to share. So the question is no longer whether patients with muscle diseases should exercise, but rather what types of exercise produce the best outcomes, okay? And so this does reflect the broader context of muscle disease. And we are still in very early stages with Duchenne, but more recent literature is really promising, and it's showing that exercise can be safe and effective. But with that being said, we also understand that the medical landscape of Duchenne is changing rapidly, right? There's new disease-modifying treatments. We can speak to that with how many pharmaceutical companies are here, which is amazing. But we don't know that much about how exercise and these pharmaceuticals interact. And so there's a lot of need for ongoing research to determine optimal dose and intensity of these types of exercise. And then my last slide is just some lovely key takeaways about physical therapy. So hyping up my own job, but we play an essential role in providing care for individuals with Duchenne. And these programs should be individualized. They can include all of those activities that we talked about previously. And this emerging literature really does speak to the safety and effectiveness of both aerobic and resistance exercise. But again, highlighting that we do need to appropriately prescribe them and monitor. And then lastly, exercise research is continually evolving with growing evidence to help support best practices. So with that, I thank you all for listening. And if anyone has any questions, I'm happy to take them. I'm also happy to just talk with others. Yeah.
Can you talk a little bit about the difference between school-based PT and then like a community-based program?
Yeah, absolutely. Thanks for that question. So the biggest thing, right, is that school-based PT needs to be educationally driven. So the goals have to relate to, in some way, their ability to academically perform, versus community-based therapy can be focused on truly like the patient or the family's goals. I would say that's the biggest difference, and there are and have been situations where we recommend both, depending on where the child is, what the child's needs are. If they don't have a lot of educationally driven goals and they're just working on stretching in school, it may be helpful to get into a pool type setting and all of that. So thank you for that question. Anything else?
Also, Nicole, maybe
Yeah.
mention, the role of these outcome measures that we do in clinic that become even more crucially important for with these new disease-modifying drugs. Frequently, we rely on those measurements every 6 months in order to get access, continue access to the drugs. So that's also another very important role of physical therapists. We need to document, like you said, either stability or improvement in order to continue to access these drugs.
Absolutely. I think that's a great point to be made, right? There's another facet to it. It doesn't just tell us how kids are progressing. It also can help secure medications and make sure that we are demonstrating stability or, in certain cases, some improvements. Absolutely. Thank you for bringing up that point. Yeah.
Yeah, our son is 6, and he is receiving exon skipping treatment for the 1951 study. And he's become much more confident in his abilities, like climbing rope ladders and things like that, which I would assume is more than moderate exercise. But we don't want to, stop or like stunt his confidence. So I'm wondering your thoughts on his abilities to run fairly long distances and climb rope ladders and trees, and he wants to do all those things. So any thoughts on it?
No, that's a great question, and I think, to an extent we have to let kids be kids, right, and put them in safe. I feel like this is really echoing now. Sorry. Put kids in safe positions to do activities that still allow them to be kids, and without necessarily knowing the full picture, right? In certain instances, certain activities can be totally safe and appropriate, but just scaling them back, monitoring if there's pain or fatigue or anything like that, it can be very helpful in terms of management. Also, one of the other big things that we tend to try to talk to boys really early about is like self-management. So understanding their own bodies, being able to take a break if they need one. So I think that's another really important and valuable lesson that you could instill in your child as well, is if an activity is not meeting my needs or it's too much, what do I do to then accommodate that? So I hope that helps a little bit, but those would kind of be my best recommendations. Yeah. Anything else? Awesome.
Thank you so much. And according to our agenda, it's break time, but what do you think, since we're so ahead of the game? Do you want to keep going with the cardiac?
Yeah, let's just do one.
Yeah.
We'll do one.
Okay, so next we will bring up Dr. Michael Collins with Cardiac Care, Cardiology Care.
Yep.
Okay.
Perfect.
All right. Everyone hear me okay? Not echoing too much. Thank you to the Jett Foundation for organizing this, and thank you to all of you for, coming out on your Saturday to spend time with us. So I just wanted to say that's, really appreciated by all of us here. So I'm Mike Collins. I'm one of the pediatric cardiologists at the University of Rochester, here with our, motley crew. So, why is the heart affected? So, cardiac and skeletal muscle are different, but certainly there are like many related proteins that, that are overlap and have, and are affected. And both of them contain dystrophin, which is obviously affected in Duchenne muscular dystrophy and many neuromuscular diseases. And so disruption in dystrophin leads to dilation, enlargement, and ultimately dysfunction in your skeletal muscle, but also your cardiac muscle. And so fibrosis and scarring can lead to kind of risks from a heart rhythm and conduction aspect, and then, what we frequently refer to as cardiomyopathy. So, here's just kind of a little breakdown of that, but like cardio meaning heart, myo meaning muscle, and pathology indicating just that there's some disease or abnormality to those things. And so you will hear us, refer to Duchenne muscular dystrophy and kind of the related cardiomyopathy that they can develop over time. And so, what kinds of symptoms do Duchenne muscular dystrophy patients develop? And this is really, can be very difficult to tease out sometimes. And, not just Duchenne's and not just kids with neuromuscular diseases, but like pediatric heart failure acts a whole lot differently than the typical adult heart failure. Even when, if the heart's not squeezing well and fluid backs up into the lungs, we don't hear the classic crackles that you do in like a 60-year-old with heart failure. Kids tend to not get the same swelling in their legs and extremities that adults do. And so that's, that's unique. That's something that I deal with every day in pediatric cardiology, but then you can also imagine that someone who's affected neuromuscularly in terms of like what is their ambulation, what is their overall ability to expend energy, and we just had a great physical therapy talk, but obviously that can be difficult to tease out, like, okay, how much of your symptoms are purely musculoskeletal, how much of them are respiratory, and then how much of that leads to, okay, is your heart affected, or are all those other things affecting your stamina, your energy, things like that. So those are very difficult things to tease out purely by history and physical exam, which is why we're relatively aggressive about, screening you with EKGs and echocardiograms, because those can tell us things that the patient or the parents or the family can't necessarily tell us, or at least like not quite as precisely. So when does the heart tend to be affected? And I should actually back up a little bit. And I'm not that old, despite how my back sometimes feels in the morning. But when I was in medical school and training, like everything I learned about Duchenne and Becker's muscular dystrophy is that it's musculoskeletal, the respiratory failure is what those were the squeaky wheels. And we have all these friends from pharma, like we've made a lot of advancements in terms of steroids, in terms of disease-modifying drugs, in terms of our devices for respiratory support. The heart has crept up in terms of how it affects these patients and whether it's going to be a squeaky wheel or not. And so now there's pediatric cardiology and cardiology have more of a role to play than they did 10, 20, 30 years ago. The average age of onset, reading through various aspects of the literature, is that typically around adolescence is when you might start to see imaging findings or evidence of heart failure, even if the patients are not significantly affected in terms of their respiratory status or in terms of their stamina or energy. And certainly by the time they're reaching adulthood, the vast majority of them have some sort of cardiac involvement. But again, they're often not symptomatic. So these are the current screening guidelines, and I always tell people guidelines are not they're not the 10 commandments, they're not written in stone, but they're just kind of this is where to start, and then you assess the patient and decide how often do we need to see, are you exhibiting signs or symptoms, or are your imaging findings dictating that we need to be a little bit more aggressive. But under 10 years of age, we tend to see you on every 1 to 2 year basis and perform a physical exam, do an electrocardiogram and do an echocardiogram, so the ultrasound to look at the anatomy and structure and function of the heart. And then after 10 years, we're usually increase the frequency of screening to say we should see you on an annual basis. But obviously, if we're having findings that dictate we should see you more frequently, every 6 months, something like that, then obviously we do that. And certainly as kids get older, the ability to see things via ultrasound gets a little bit more difficult. And cardiac MRI is a little bit less accessible. It's a little bit more expensive. It's anyone who's sat in an MRI machine can tell you that it's not comfortable or a pleasant experience to lay down flat, and certainly that's something for a patient with neuromuscular disease and maybe some impaired respiratory status to sit still for 45 minutes flat on their back, but is something that can give us a little bit more data, especially in terms of assessing the tissue, is there fibrosis and scarring? It gives us another way to assess the function, and so that is something that we consider, especially when their echocardiogram findings are becoming more difficult to assess. And then we also, a lot of this focus is on boys, but female carriers also have a risk of being affected. It's typically not early. This is generally something that affects female carriers in adulthood, middle age, but starting in adolescence, we usually see on a relatively infrequent basis every 3 to 5 years. I kind of think that the adolescent females that I'm seeing is not so much that I'm going to stamp out disease in pediatrics, but more to remind you, hey, do you remember doing this as a kid? This is something that you should still look out for, and especially if you're in your 20s or your 30s and you're feeling, I can't, I used to go on 10-mile runs like Dr. McKenzie here, and now I can't now I can't keep up with those, or my times are decreasing a little bit. So, so things to kind of keep in the back of your mind, like I should be aware that these things might affect my heart down the line. So current therapies. So all pediatric cardiology therapies are really a lot of it is trickled down from adult cardiology, and some of this is just limitations in pediatric studies, and also just kind of purely ethical issues. So there's hundreds of thousands of adults with heart disease, and they can consent to a study where say, I'm going to take this medication. It may or may not be a placebo. I accept the risk that I might die sooner or something like that. That's obviously more difficult to do in pediatrics. We don't have the same randomized control trials, and we don't have the same numbers to kind of come to strong conclusions. So a lot of times we use drugs that have been studied very well in adults and extrapolate that to pediatrics and say, okay, beta blockers or ACE inhibitors have been shown to reduce mortality in adults with heart failure, and therefore, we're going to prescribe it to kids in heart failure. That landscape's changing a little bit. There are more true randomized control trials in pediatrics, but the numbers are not quite the same. And sometimes we don't, necessarily see the same differences. We still generally tend to use those same medications because physiologically they make sense. If you decrease the blood pressure, if you decrease, the stress that the heart has to go through, that should, benefit remodeling. That should, and we do have some studies that have shown those things, but it's mostly just to say that there are some limitations with the therapies that we currently use for pediatric cardiology. So current guidelines generally say the initiation of an ACE inhibitor like lisinopril or an angiotensin receptor blocker like losartan have shown benefits in patients with Duchenne muscular dystrophy, and the guidelines are to start, at least by 10 years of age, that we should be starting these as preventative medications, even if you don't have any cardiac symptoms, if you don't have any findings on echocardiogram, because they have been shown to be beneficial in these patients. This was, this is not to get overly heady, but this is probably the most recent literature I've seen in Duchenne's patients with regards to their, kind of cardiomyopathy and heart failure. This was, still not a true randomized control trial, but kind of a retrospective study out of France that looked at, 600 patients, which, Dr. Cole here will say, look at adult studies that have tens of thousands of patients, and this is a joke to her, but this is pretty good numbers for a pediatric heart study. And it looked at, essentially looked at patients who were admitted to 8 French hospitals for various reasons. They did try to kind of exclude diseases that might affect the heart. So for example, being admitted for influenza has a risk of kind of viral myocarditis, and trying to sort of take that off the table in terms of oh, you were just admitted for, a surgery or some other musculoskeletal reason. But, what were your kind of comorbidities with regards to cardiovascular outcomes? And it did show that, patients who were on a preventative ACE inhibitor versus not on a preventative ACE inhibitor seemed to have better outcomes. There are some interesting things about this study, mainly patients in kind of this certainly under 5 years old, is not the typical aged patient where we're starting heart medications, certainly not kind of prophylactically. So it's hard for me to look at this study, and I couldn't quite tease it out if those patients kind of already had cardiac symptoms and therefore were kind of on treatment medication rather than a preventative medication. which still makes sense for you to be on a medication if you're having cardiac symptoms or if you're having evidence of mild or moderate heart dysfunction. But kind of those younger patients, it's kind of interesting because I don't think most people, certainly nationally and internationally, are usually that aggressive about starting cardiac medications under 5 years old. So part of me wonders if those kids that were studied and affected were maybe more severely affected compared to someone who doesn't have any cardiac findings at 8 to 10 years old and we're starting a medication. With all that said, I think this shows pretty good evidence, with obviously whatever grain of salt you have to take from it, that preventative medication, because we know that the heart will be affected, and that we have medications that have been shown to be effective, even down into kind of like these pre-adolescent kids, that being relatively aggressive with pharmacotherapy makes sense, and I think can improve cardiovascular outcomes.
Like, can I ask a question?
Yeah.
So the fraction of 0.1 means 10%, like just looking at B, for the 6-year-olds, like roughly 10% are hospitalized for heart failure at 6, is that?
No. These were patients, the cohort of patients were patients who were admitted. So it was just the study was from patients who were already admitted to the hospital for a non-cardiac reason.
Of the patients that are hospitalized.
Correct.
And then the y-axis is fraction hospitalized for heart failure. That's what I was confused by.
I think that was a subset of patients who were specifically hospitalized for cardiac reasons, versus on the left is patients who are hospitalized for non-cardiac reasons.
Okay. And I know you touched on it, but so if I'm reading this correctly, around age 4, that's where the balance flips. And in these centers, looks like most patients, from what we can infer from this, are on a cardiac medication by 4.
It's what I can't tell from this study is, were all of these patients, were the 2 and 4-year-old patients in this study, did they have normal echocardiograms at baseline and they were on a preventative medication, versus did they have evidence, were they severely affected Duchenne's patients who already had who already had mild or moderate dysfunction and were being treated? Because essentially, like the granularity of the data is that here's a patient who's hospitalized, were they on a medication versus were they not on a medication?
Okay.
Mostly because I think we are erring towards being more aggressive and starting cardiac medication treatment earlier, but I'm not aware of people being as aggressive as starting 2, 4, 5-year-olds on medications. That might be out there, and I'm just unaware of it. But that seems more aggressive than we typically tend to be in terms of preventative treatment.
And I don't want to derail you. But
Yeah.
Could you speak to the risks, or are there risks to starting early? I mean, with these medications, I think they're pretty safe. So I know there's a movement to starting earlier and being more aggressive, and increasing dose, adding the second medication. What's the downside of that?
I don't think there's much of it. I truly don't think there's much of a downside. We, certainly ACE inhibitors and ARBs have some kind of angioedema, allergic risk to them. And, we do kind of look out for kidney side effects, and especially for younger kids who are a little more prone to, getting gastroenteritis, getting a bad stomach bug, getting dehydrated. Your kidneys can certainly be affected if you're dehydrated for other reasons that tend to, occur less often than in adults. I think the only other, quote unquote downside is over medicalizing, and I think that that's something that is probably not as big of a deal in Duchenne's. I think we always try to be cautious in pediatrics of, hey, when we start you on a, especially if I'm just having a kid who has, say, a family history of dilated cardiomyopathy and they have a gene associated with it, but they're an otherwise healthy person, that kid probably doesn't take many medications at baseline, and I'm understanding of, when I start a 10-year-old on a lifelong medication, that's not a big deal. That said, Duchenne's patients are obviously very, accustomed to, okay, we're getting treated with steroids, we have devices, we have, it's less of kind of like a threshold where you go, oh, I went from someone who doesn't take any medications to now I take a lifelong medication. But generally, I think the downsides in someone who's kind of like used to being on a medication or being on multiple medications, having lots of follow-up, is generally like you're kind of like past that barrier. So, certainly things like this I think have changed my practice in terms of being, a little bit more aggressive, starting medications earlier on the basis that I think this, is beneficial in the long term.
So I think it's fair to say that the field, the community has really moved towards definitely start preemptive cardiac medication, say between 6 and 10, definitely before 10, that the risks are very low, but that the evidence is not ideal or precise. It's not a randomized placebo-controlled trial. We don't have that kind of data, so I know that sometimes it might be a little frustrating for families and for cardiologists to really agree, but at some point it seems like the community of experts have reached this consensus, and that's what we're doing now. And then the other thing also that there might be nuances about, remember the dystrophin gene is a huge gene, so there are also some exceptions that sometimes certain mutation might have a more aggressive cardiac phenotype. So that's why it's very, very good to establish cardiac care as soon as you have the diagnosis made, just to make sure that there aren't any other unusual situations that are genetically driven. So.
No, I agree. And actually, as I was preparing for this talk and reviewing some of the literature, I came across at least one study that was saying hey, these guidelines have been out for say 5 to 10 years, but prescribing practices have not necessarily been as aggressive. If you poll cardiologists and how aggressive they are about starting medications compared to and how strictly they're following guidelines, that those practices don't necessarily match up. And I think that essentially comes down to okay, awareness and communication that this acts, this is a different scenario than dilated cardiomyopathy in patients who don't have neuromuscular disease.
And there is work on new guidelines coming out, so updating those because we realize those are old.
I'll talk a little bit about gene therapy since this is, this is kind of like a relatively hot topic. It's, truly, I think it's too early to say what the cardiovascular outcomes are of gene therapy like Elevidys. I think we've certainly seen some positive musculoskeletal outcomes, and both in data and anecdotally. I have patients who tell me oh, he seems more stable, the balance seems to be a little bit better. I'll talk about the troponin because it comes up for us all the time, and it's can be very frustrating, and it's frustrating for families, and it's also frustrating for us because I think we end up in this place of we don't quite know what to do with it. So troponin is an enzyme that's found in your cardiac and your skeletal muscle tissue. There are different subtypes. Some are a little bit more specific to cardiac muscle. But generally, the level in your bloodstream, it's in your heart muscle. It's not in your bloodstream. So, when you do a blood test, the troponin level should be relatively low. If you're a 60-year-old smoker diabetic who goes to the ER with chest pain that radiates to your left arm, and you're having a heart attack, the troponin level is the first thing that they'll check, and generally it's sky high because you're having a heart attack. You're having poor blood flow to your heart muscle, and so your heart muscle is inflamed or being damaged or even dying, and so that troponin is leaked into the bloodstream, and we see very high levels. And so for an adult, they take you to the cath lab and balloon and stent open, whatever coronary artery is blocked or something like that. And then it can also be elevated if you have some sort of myocarditis, you have the flu, you have COVID, and that kind of systemic inflammation is affecting your muscles, your respiratory system, your cardiac system, and so the troponin is elevated in those cases as well. Interestingly, Duchenne muscular dystrophy patients who have no cardiac symptoms, who have a normal echocardiogram, like nothing wrong with their heart, lots of them have normal troponins, but there is a percentage of them that have some elevated troponins at baseline. We don't quite know what to do with that. This is the part that's very frustrating, I think, for all of us, is because we don't quite know what that means. And so far in our studies, we've also found that it is not necessarily prognostic with regards to giving our kind of gene therapy. So we always check it before gene therapy. We check it kind of in there, you have pretty frequent lab draws. After gene therapy, we've seen patients who have a rise in troponin, which I think is, fairly expected. If you give a vaccine, if you give gene therapy, if you do something that causes a systemic inflammatory response, you're going to have an elevation in your inflammatory markers, you're going to have an elevation in your liver enzymes, your cardiac enzymes, et cetera. So it's not wholly surprising that it happens, but we have not found that the number necessarily correlates or predicts a negative outcome versus a positive outcome. So we check it, and it kind of dictates like, oh, if the troponin's rising pretty quickly, should we get an echocardiogram sooner to make sure that there's nothing acutely happening with the heart? Is there any kind of myocardial inflammation going on? With that said, we've been pretty fortunate that we have not had any, despite one or two patients having significant troponin elevations after gene therapy, we have not seen any like true myocarditis, like someone who ended up in the ICU or needed escalation in cardiac care because of those things. There is a little bit of a caveat that for the most part, we have not given anyone gene therapy who has any sort of kind of cardiac dysfunction at baseline. Everyone has had, both by rules, but also kind of de facto, like, hey, we're worried about you having a bad outcome, and so we've kind of like tailored the who gets gene therapy to people who already kind of have relatively healthy hearts, like no one who's had more than kind of like borderline or mild dysfunction. Essentially all the patients who have received gene therapy have good cardiac function at baseline. So other future therapies, I didn't talk that much about kind of like the rhythm conditions. I don't think of it as necessarily a primary arrhythmia problem as much as if your heart stretches and dilates and doesn't squeeze as well, the kind of arrhythmia kind of develops from that because your conduction tissue gets strained with that. So certainly there's roles for anti-arrhythmic medications, and usually there's some overlap in kind of heart failure medications and arrhythmia medications. But certainly anyone who has kind of significant arrhythmias that we feel like, oh, you're at high risk of having something that needs to be shocked. There are ICDs, implantable cardiac defibrillators, to shock you or pace you out of an abnormal rhythm. I don't want to spend too much time on transplant, but there, suffice it to say, there have been case reports of Duchenne's patients who have gotten heart transplants. And I think, part of that is because, it was kind of a non-starter conversation 20 years ago because, the overall lifespan was, not that was that one of which that, are you going to benefit, how long is this heart going to benefit you versus are the other issues going to be, the squeaky wheel, so to speak. I think ventricular assist devices, are an area that are probably, we're going to see some advancements in 10, 20 years. I don't know if anyone here has like a family member, an adult with congestive heart failure who's had a ventricular assist device, but I kind of showed have a picture right here where there's a lot of different ways that cannulation can occur, but essentially there's a machine that takes blood from the heart and has some sort of centrifugal or centripetal pump and then sends it out. So essentially that it's an artificial pump for the heart. And there's obviously infection risks with a device sitting in your body, and then also blood that's going through a machine has a risk of forming clots, and obviously this blood flow is going to your body and to your brain, so there's a risk of stroke. So everyone with a ventricular assist device has to be on anticoagulation for prevention of stroke. But in the adult world, they'll do something that we call a destination VAD, meaning like you get a ventricular assist device, and that's what takes you to whatever the end of your life, so you get it at 60, 70 years old, and you say, like, hopefully this lasts you 10, 15, 20 years. In the pediatric world, we tend to not place ventricular assist devices solely for that purpose. We generally do it as we're doing this assuming that you can recover from a bout of myocarditis, or we're doing this as a bridge to a heart transplant. I think that is changing. That's changing, and that, there's nothing kind of like medically wrong with it. I think it's just an ethical, boundary that we're starting to cross, is to say that, hey, if this is something, if your heart is not pumping well, and we have a machine that can help your heart pump better, even if, say that we don't think a heart transplant makes sense for you, but if this is something that can prolong your life by 10, 15, not only prolong, but improve your quality of life. If all of a sudden, like, that improves your respiratory status, if that improves your stamina, your energy, I think that's, I think the landscape on that is changing a little bit, that we're a little bit more relaxed, or exploring that as an avenue, rather than saying, like, oh, we don't want to just do this and not have kind of a transplant as the future option, is that this may be something that truly benefits you. And so that's, I think that's something that is, in the future, and I think that discussion will change over the next 5, 10, 20 years. So, I think that's everything I have.
So, Michael, can
Yes.
you say, so in terms of the transition, where we said, the Rochester model, which is different from other multidisciplinary clinics, the neuromuscular home remained the same from newborn screening until end of life. We don't transition. But for the subspecialty we do, so in our model, our Duchenne patients, they transition to the adult heart failure clinic. And usually, is there a precise age? I know in different hospital is different. Sometimes it's dictated also by the fact that if you end up needed to be admitted, certain ICU will require, there is an age cutoff. So in your experience, usually we transition our patient right at 18 or 21?
So it's a great question. I think the answer is we have no set rule in pediatric cardiology, and part of that stems from, not to talk about non-Duchenne things, but because we have patients with congenital heart disease that didn't used to live to adulthood, and adult cardiologists just don't have a ton of experience dealing with these things because the anatomy is all wonky. We do surgeries that they've never had to learn about or manage. We tend to not have like necessarily a strong cutoff, and we also have kind of adult congenital cardiology as a specialty that's emerging. I think, and I certainly don't want to speak for all pediatric subspecialists, but I think a lot of us certainly in cardiology have just kind of gone with, like, well, if you turn 18, if you're going to school, going to college, if you're going to be somewhere for, say, like 4 years, don't go see a specialist that has to learn you only for you to, go off and live somewhere else or something. So there's really not an age cutoff for us, and I think a lot of it is it's on a case-by-case basis. I sometimes if mom or dad has their own cardiologist, and and they live pretty far away, and coming all the way to University of Rochester is a hike for them, and there's a cardiologist who feels comfortable managing the heart failure or preventative cardiology for Duchenne, then I think if this is going to be more convenient for you to not drive an hour and a half, and you're going to see someone who's already familiar with you, that's totally fine with me. But I'm also not in a rush to kind of boot you out of our clinic. Yeah.
This is along the same vein as my last question with gene therapies and exon skipping. Is there concerns or research or thoughts on maybe like a greater stress being put on the heart if the body is doing what it would not have naturally done without these therapies?
I think the answer to that question is possibly, but we don't know. I think the answer is possibly, I'll kind of use Becker's muscular dystrophy as an example of, their cardiac involvement is usually not as frequent as Duchenne muscular dystrophy. That said, the Becker's patients who tend to have cardiomyopathy, sometimes have pretty severe cardiomyopathy. And I saw a few, Rochester is not a pediatric heart transplant center, but where I did my training was a pediatric heart transplant center. And there were a number of like Becker's muscular dystrophy patients who were listed for heart transplants who had very poor function. And part of that may be because they stress themselves more than the average Duchenne patient. But that said, I think there is also clearly, as Nicole was saying, is like it's not that exercise is not beneficial. It's that figuring out what the correct degree of exertion is. Like that, that's the real question. And this comes up with kind of congenital heart disease. Is that everyone's seen an adult with bad congestive heart failure who looks terrible. It's clearly not to our benefit. I think 30 years ago we were much more prescriptive about like don't stress yourself, et cetera. And I think there's negative mental health consequences to that, but also clearly like compounding a genetic or congenital heart disease with adult heart disease is clearly not the right answer. So like obesity, diabetes, all those like metabolic risk factors, if you compound that on top of your underlying genetic syndrome, that's clearly not going to be beneficial for you in the long term. So I think that there's probably we're still finding the right answer there, but I certainly think it's probably somewhere in the middle. Not to be a centrist bias.
And then we have a young daughter, and I know you're saying like girls, if they're diagnosed to it in their teens, but there was a mention about if it's in your if there's like a problem in your family, something genetic on top of it, that it may be a concern. So is there any benefit to having those tests, like say the elementary age years or something like that?
I think the answer is possibly, but then you like, not to take the public health view, but like then are you having to do a whole lot more testing, or like is that going to be care for just like a Duchenne patient is already pretty costly, and then if you're adding that onto a family who's already like using up a lot of their resources, and I don't think we have data to say that like we should start female carriers on medications that will definitely improve things. And then that sort of gets back into like, if you're an otherwise healthy person who doesn't take anything, and then are we going to tell you at 10 years old, take this medication for the rest of your life for some potential benefit versus not, and for females, there's also kind of like teratogenic risk that you have to worry about with, with pregnancy and things like that. So I think it's a good, I don't think that's like, as sticky of a question right now in terms of being more aggressive about it, because I don't know how much we change management, especially in childhood, without the same like ability to predict like you'll be affected versus you won't be affected.
One more question.
Yeah.
Are the genetic concerns, is that like something different than like heart disease as an adult? Is that, or is it something more specific, more rare? In my family, there's like adult, but not a kid situation, a child.
Yeah, so I do think those are separate pathways. Okay. I do think those are separate pathways, but like I said, it's clearly not beneficial for you to like have some underlying have an underlying genetic risk and compound the familial risk. So for there being like, oh yeah, dad, grandpa, Uncle Bob, like were all smokers. They like didn't take great care of their health. They were all overweight, tended to have heart attacks in their 30s or 40s. Like while that's not necessarily genetic, we do know that you have some increased. If multiple family members had coronary artery disease at an early age, your risk is higher than probably the general population. And so I think that behooves those people to, I don't want you to become overweight. I don't want you to develop diabetes. I don't want you to develop high cholesterol. And some of those things are non-modifiable, but some of those are modifiable. So I want this is kind of like establishing healthy habits when you're younger is going to make it easier to carry those things forwards through young and middle adulthood.
Like some
Yeah.
and not to go too far on topic, but some of the adult cardiologists that are seeing some of our patients are putting them on the
And, what is the rationale for that, and do you see that coming into the peds world?
I think we see a little bit of it coming into the peds world. Like I said, a lot of things trickle down from adult heart failure management and find our way into peds. And there's various ways. Like sometimes it gets studied and then enters into practice. Certainly, there are severe cases where we kind of throw the kitchen sink at you, hoping that like, okay, there's not a whole lot of side effects, or having measured what are the possible downsides, and and assessing risk for those things. So I think there is some movement that we are having more of our patients on GLP-1 agonists or SGLT2 inhibitors. I don't think it's standard of care, but I do think that's that landscape's evolving.
And is the rationale solely for reducing weight and load on the heart, or?
It's a little bit of both. I think I can speak more to the SGLT2 inhibitors like dapagliflozin, like Farxiga, because that's been, it was kind of studied as a diabetes medication and then was found to be particularly beneficial for diabetes and heart failure. And then they kind of like relatively recently essentially said, we don't even care if you have diabetes, like it seems to be beneficial for heart failure. And so, patients started getting put on that. So I think I've seen 2 or 3 patients that we've started on those medications, and so I think that's entering into practice a little bit more.
I think the big question is that we don't know the effect on the skeletal muscle. It's going to be a positive or a negative. So that's a great unmet research question that someone definitely has to study. But keeping in mind that, the skeletal muscle.
I mean, the other thing is, with SGLT2 inhibitors, there's the, you urinate more. It helps with diabetes because you urinate more sugar, but your UTI risk also increases. And so for someone who's like, hygiene, if genitourinary hygiene is an issue, so I saw that with at least one of my patients where we had to kind of weigh the risks and benefits for someone who did not have the best hygiene practices, and certainly something to consider in patients with neuromuscular disease. Other questions?
Thank you so much. Great questions. Buddy, okay, so up next, we have Dr. Catherine Kroll, and she's going to speak about pulmonary care. So, Catherine? And you can use this for doing the slides, and this is working.
Oh, perfect.
All right.
Thank you so much. So as everyone said, thank you so much for having us here and for all the families who are joining us. My name's Kathy Kroll. I'm one of the adult and pediatric pulmonologists, so I come at this with kind of a little bit of a different view, and was hoping to kind of just speak to you about the overall pulmonary care in patients with Duchenne's. So objectives, we're just going to quickly talk about the respiratory system, how it gets affected by neuromuscular weakness, and how do we monitor for these changes that we see, and then talk about the different treatments that are kind of available out there to help support these kids. So the overall function of the respiratory system, break it down into its most basic parts, is to get oxygen in, to get carbon dioxide out, and then to cough to clear kind of secretions. But in order to do that, we have a kind of a very complex system with the lungs. Not only are we talking about the airways and the air sacs and all that support the lungs, but there's lymphatics, there's nerves, there's muscles, and there's a ton of blood vessels and all in order for those functions to occur. And so more specifically, when we talk about the neuromuscular aspect of breathing and we break down this system, it's a complex system that starts up in the brain, and there's messages and all that travel through the spinal cord, through the nerves, and then out to the muscles. And so what muscles are we kind of talking about? Well, in particular, the biggest muscles are the muscles that sit right below the lungs, that are pictured kind of at the base there, but the diaphragms, they support about 70% of breathing and help with breathing. But besides those, we also have the muscles of the chest wall. You have the muscles of the abdomen that help support breathing, and as well as the muscles of the neck. So there's a lot of different muscles and all that help us to breathe every day. And so what happens when these are affected by, different disorders or neuromuscular weakness like Duchenne's? So over time, what we see is there's kind of two big things that happen. One, when we follow just kind of the natural history of the disease, is the weak cough, and that's probably the thing that we see first. Patients having difficulties clearing their secretions, and then comes the hypoventilation, or as we call it, kind of the more shallow breathing aspect of things. This becomes more pronounced early on during sleep, because all of us, when we sleep, our muscles go weaker. And so if you already are dealing with a baseline weakness, that's going to get harder for the body to breathe. And so that's why we see it first at sleep. And then eventually during the daytime, their breathing's also going to be affected. These symptoms become more pronounced once kids lose ambulation. And so that's kind of a defining point that we kind of look at a little bit too. So what signs and symptoms are these boys going to have when they have, signs of a weak cough per se? Well, a lot of times they're going to be asymptomatic, and we're not going to necessarily know as easily until we do some of the testing. But if they do have symptoms, it's typically going to consist of some chest congestion, maybe some constant throat clearing, maybe a rattling sensation that parents sometimes say that they hear in their kids. They can also have recurrent respiratory infections. They're just infections that don't ever seem to completely clear. For hypoventilation, when the boys sleep, a lot of times it's going to be a restless sleep. They're going to be up and down. They're going to be repositioning all the time. Parents may say that they hear snoring as well. They may have the bed covered in sweat when they wake up in the morning. Sometimes they'll also have morning headaches that usually get better pretty quickly once they're awake and they're breathing more normally. They may be tired during the day, want to take naps a lot during the day. And then the other two ones that are not so well known but are mood changes, and also difficulty paying attention in school, almost like an ADHD or ADD kind of inability to pay attention during school. And then with hypoventilation, while patients are awake, sometimes patients will complain of shortness of breath, but that's not always. Sometimes they'll just say that they feel anxious, and maybe that's because they feel like they can't breathe. Their voice may also get softer because they don't have enough breath to kind of support it. And they may also not be able to speak kind of in continuous sentences. It's more kind of broken up sentences, or kind of some of the symptoms that we kind of watch and monitor for. So what monitoring do we do to kind of assess for all these changes? And I would say routinely we'd like to see patients kind of on at least every 6-month kind of schedule. And during this, one of the big things that we do are breathing tests. So spirometry is probably the biggest one, and the biggest test we look for is the FVC, or the forced vital capacity. And this is basically asking the patient to take a big, deep breath in and then blow out as much as they possibly can. So we're kind of getting an assessment of what their total lung volume is. It's not the exact same thing, but it's kind of a good surrogate so we can understand how big a breath they're actually able to take. And that's kind of the important one that we continue to trend and follow them over time. And it's been really also the one that's been used in like a lot of research studies too, to see the effect of breathing. The other one is just a basic O2 sat too, because this can be really telling to us as well. Because remember, one of the main functions is to get the oxygen in, and so if the O2 sats are starting to slowly fall over time, which they will in these patients with the hypoventilation, that can be kind of telling to us too as to how their respiratory system is doing. But more specifically, if these were the two kind of big respiratory symptoms that we came up with, the hypoventilation and the weak cough, how do we measure these more specifically? And so I would say with the weak cough, there's a specific test called a peak cough flow, which basically can be done on the same spirometry or can be done independently, but basically you ask the child to take a big deep breath and cough as hard as they can, and we get a measure of how strong that cough is. And there are certain measurements that tell us, hey, it's strong enough to clear secretions, or they may struggle a little bit more, especially during illness, so it may be something that we want to support for them. Hypoventilation during sleep, best test is a sleep study, which I know is not always well loved by patients, but truly is the best study. There are some at-home tests. Obviously, being the in-lab test is probably the best test, where they hook you up and they can measure where you are in sleep, because there are different phases of sleep, And then they can measure how your breathing is, how your oxygen is, how your CO2 is, and all that kind of important stuff. So it really gives us a good measurement as to how they're breathing at night. And then the hypoventilation while awake is probably measuring CO2 levels. And I'd say there's probably two best ways that we can do these for a lot of patients. One is called an end-tidal CO2 machine, which is a simple one that we can kind of hook up for them while they're in clinic. They get a nasal cannula that just looks like oxygen under their nose. And it gives us a relative idea of how well, they're exchanging those gases, in particular the CO2. But the other probably better one, if we really want to know, would be a blood gas, which you can get drawn at like a local lab or something along those lines that would tell us if that CO2 level is starting to climb, because that would be one of the signs that hypoventilation is becoming more prominent in the patient. So we talked about the signs, how we're monitoring for them, and then what treatment modalities can we offer to kind of combat these different things that we come across. Well, the first for a weak cough is something called a cough assist machine. So one you guys have probably seen is more the one on the right, but I put the one on the left because it had like the actual mask and all that kind of hooks up. But it's also known as an insufflator exsufflator machine, which I think is kind of telling as to how it works. And basically what it does is it pushes the pressure of air into the patient and then pulls the same pressure out a lot of times. And what that does is help remove some of the secretions and all that either the kid then is closer up in the airway that they can cough out, or you can use a suction machine or something along those lines to actually get the secretions out. Then for hypoventilation with sleep, probably PAP therapy is the treatment modality here. So this would be having a mask, whether it be a mask just over the nose, mask over the face that a lot of patients wear. There's tons of different masks now that for comfort of patients over time. But this is a machine that kind of helps support their breathing. There's a lot of different modalities that we can use, and sometimes it progresses over time as to what the settings need to be or how much breathing support the patient needs. So it can go anywhere, if you guys have heard of things like CPAP to BiPAP to more advanced modes that we can use through this kind of what we call non-invasive, because it's something that the patient can kind of take off and on. And then when the hypoventilation occurs during the day, I think we have a lot of different options. One is there are some patients that like to continue to use their PAP therapy during the day. They find it comfortable and they take it off for short periods of time, maybe to eat, and then put it back on. But they're comfortable doing that, and that's what they prefer to do. What's pictured here is called a sip and puff ventilator. And so basically this is a special type of ventilator that they can kind of carry along and then use kind of on the side and kind of put their mouth on and help give them a bigger breath whenever they feel like they need it. So it's kind of like an on-demand kind of ventilator machine. And then eventually there's also a trach and a vent. If that's something that fits with what the family or child or a young adult kind of wants, that would kind of fully support their breathing, with the trach being kind of a tube that goes through the neck and then connects to a ventilator machine and gives them kind of full breathing supports. So a lot of different options that we can kind of talk about and discuss with the patients as that progresses. And that's all I really had. So questions for me?
So similar to what we talked about cardiology, it's very important to, in our experience, the pediatric pulmonologists are very, very tuned in our neuromuscular diseases. And it's important to remember that this intervention, like this monitoring that Kate just described, and the intervention
And to kind of just echo off that, a lot of times if it is PAP therapy that's going to be needed, when they come and say they get an acute illness from getting a cold or they get an infection or something, a lot of times that is going to be in an ICU setting, whether it be in peds or the adult side. And so to kind of back off that transition thing too, I think we're trying to work a little bit more to get it at the kind of 18-20 range. And that's kind of one of my goals too, is to kind of help, since I do both, to see them on the pediatric side and then make it not so much of a shock on the adult side, to try to smooth over that transition. Because it can be upsetting if, you know, you all of a sudden get sick and you're 18 or 19 or say even 20, and then you're thrown in an adult ICU. It's a much different experience than, say, in pediatrics and that kind of thing. So helping to try to bridge that gap, I think, is key.
What are your strategies to help, like, you know, teenage years are tough enough. What are your strategies to help our teenage and young adult populations more compliant with their follow-up and with using some of these therapies?
Yeah, so I feel like the biggest struggle that we see in particular is the PAP therapy. You know, a lot of times they get to a point they're like, I don't want to wear it. And sometimes by the time they reach, some of them aren't starting it until they're mid to late teens too. And so they're like, I don't like the way it feels. It's a weird sensation. And it is. Like, if you've ever had to have something blowing on your face, it's a different feeling, and to have to sleep with a mask, whether it just be over your nose. And I acknowledge all those different types of things. So I think having a discussion with them, I think, is one of the important things. Like, what is your barrier to using it? Like, is it that you forget? Is it that you don't like the way that it feels? Is it the pressures? Because sometimes, like with the pressures, there are things that we can adjust, right? We can slow how fast it ramps up for them. We can change, you know, the settings a little bit and then slowly increase them over time to the more optimal settings for them. If it's the mask, because they're like, I feel too claustrophobic, I don't like the big mask on me, then working to find a smaller mask or a mask with pillows or something, I think, is the important thing. And then, so I think that's a lot of what I do, is just talking about those kind of things with them and finding out from them, like, what is your barrier to it? And then talking with them. And then, honestly, sometimes it's getting those PFTs. I've had some young adult guys come in, and when they see their PFTs and they're like, ooh, my breathing's really not doing well. Sometimes that alone, having a discussion with them right then and there and saying, hey, you know, if you started using your PAP therapy, let's see where this would go, or let's prevent it from going slower. And I've had some of them, you know, buy into it that way. And then they come back and they're like, hey, I've been using it every night. And then the funny thing is, they'll tell me, like, it's great. They're like, I feel so much better. My breathing feels better. I never knew that it could be this good. But I would say patient buy-in is the hardest one. So I guess trying to meet them where they're at and then working with them to make them comfortable with it has been the approach I've taken with them. Mm-hmm.
What is it about the shift from ambulatory to being non-ambulatory that causes the difficulty? Is it not moving as much, so your lungs are not working as much, or is it something about your body brain and how it's that?
So it's probably a little bit of both. I think, you know, I think when you go from the ambulatory to non-ambulatory, there's obviously a loss of muscle strength. And your muscles of breathing are the same. If you continue to use them and strengthen them, the stronger they're going to get. If you don't, the weaker they get, just like any other muscle in the body. I will say that, you know, in a lot of these patients too, we're also compounding this probably with scoliosis playing a role in some of these patients as well. And so if that's progressing over this time too, that's going to affect their breathing as well, because that's going to change the cavity of the chest wall and how much space the lungs have to expand and breathe. So I guess, yeah. So I think it's a combination of different things in there, but I think it's really just the progression of the loss of strength. And that's what we really see at that time frame shift. Anybody else?
Dr. Paul Vermillion, come on up. And I think you should be all set right here. Thank you so much.
Presumably this clicker works.
Yes.
Great. So thank you for having me. Sorry, I'm in my scrubs. I'm working in the hospital right now, and I'm technically on call, so if I have to answer a page, I sincerely apologize, but I don't think so. And so I am supposed to talk a little bit about palliative care, and It is quite possible that somebody has like a physical reaction to hearing the term palliative care. It's so often associated with death and dying, and it's kind of scary to hear. And I hope to, and actually for that reason, some peds palliative care groups stopped calling it palliative care, and yet a rose by any other name is still the same thing. So it's still the same palliative care. So I tend not to shy away from the term. But I do try and center the discussion on a little bit different thing. And so I really love this piece by Dr. Eric Cassell back from 1982, where he talks about the nature of suffering and the role of medicine. And he spends a lot of time in this really honing in on this idea that medicine is more than treating a disease. It looks a little bit small on the screen, so if you look sort of midway down the first paragraph of the abstract, suffering is experienced by persons, not merely bodies, and has its source in challenges that threaten the intactness of person as a complete social and psychological entity. It can include physical pain, but is by no means limited to it. And so we really can't only treat the disease if we're not also treating the suffering that comes with it. And in that lens, palliative care tends to the suffering of children struggling with serious illness, as well as their families and their communities. And so I will breeze through, just because everybody associates palliative care with hospice, that hospice is this insurance benefit for people who are in the last 6 months. And the traditional thinking of palliative care was that you do this curative or disease-directed therapy, and then hospice takes over when that's gone. We have hopefully gotten more towards this idea that it happens concurrently. And our hope within our multidisciplinary clinic here at Strong is really that we are doing them at the same time for all of our patients. And so it's just a medical specialty like anyone else, tending to people struggling with serious illness wherever they are in that trajectory. And there's no mandate to limit, and there's no sort of inherent treatment decision because you are being seen by palliative care. The domains that we think of as part of palliative care is all of these, pain and symptom management, communication, helping families hold room for hope, helping clinicians hold room for hope, helping provide anticipatory guidance around what families and patients might experience, helping with the coping with serious illness, tending to spiritual needs, and also bereavement for some. For the sake of this talk, I'm going to focus on just a few of them. Thinking about holding room for hope, I often really think about this, I guess it's called a poem, it's sort of prose, by Emily Pearl Kingsley, and if you haven't read it, I suggest you do. It's a really beautiful piece where Emily sort of describes the experience of having a child with disability, with special needs, as akin to having planned this wonderful vacation to Italy. And you have made plans, you've been hoping for it your entire life. As soon as you found out you were pregnant, you start making plans for what that child, what you will be like as a parent, you start creating your parental identity. And then in this piece, you get on the plane and you're bored, you're really excited for Italy, and then you deplane in Holland. And you have to figure out, you're mourning all the things that you don't get to do because you're not in Italy. And you're sad about it, you're having to adjust, and then ultimately you realize, if I spend my whole life being upset I'm not in Italy, I will not enjoy the things that are Holland. And so it's a really nice piece. And in that way, I will often think of my job in palliative care as being a bit of a tour guide to Holland. This idea that, you really knew a lot about Italy, you knew what you were excited about for Italy, you knew what to expect, you knew what you had to be careful of. And you don't know anything about Holland because you weren't actually planning on being here. And so our job in the medical community is to try and help you acclimate to Holland. Thinking a little bit about coping and spiritual care, we think of spiritual, and I like to give a little caveat here that I say spiritual and everyone starts thinking I'm talking about prayer and reading the Torah or religious ceremonies, and that's not what I'm talking about when I talk about spiritual care for most individuals. We are talking about sort of a secular spiritual care, this idea that everyone wants to be part of something larger than themselves. We have a sense of self-identity that is important and spiritual in nature. And so the things that children all struggle with are the things that children with Duchenne struggle with. Things like identity formation. and trying to figure out who your people are. Where do I fit in? You know, children with Duchenne are also struggling with where do I fit in? Who are my people? Not everyone identifies best with other children who have Duchenne. And so some children want to find a community of people with disability, someone going through something similar, and not everyone. Some people just want to find the group that really loves Fortnite. And so there's a difference in how children with Duchenne might connect, but everyone is looking for that connection. Everyone is also looking to exert some control over their life and struggling with the loss of control. My favorite example of this is the girl impulsively cutting her bangs because she wants to take control over something and invariably regretting it. And we see in any child with chronic illness that they will often struggle with loss of control and feel like so much has been taken from them, that they have control over so little, that they stop taking medicine, or they stop doing their vesting, or they do something to take some control and have some agency. And so it's a reminder that we have to build that into their life. Like any child, we have to start giving them some control over things. And that gets at this idea of graduated independence, that again is such a natural part of childhood and plays out slightly different in individuals with Duchenne. You know, in the typical childhood, this looks like starting to think about driving and getting a car, and now you don't need mom to take you or dad to take you wherever you need to go. It might look like leaving home, going to school, getting a degree, getting a job. And those are sort of the big end goals of independence as we think about our children growing up and being independent adults. But it starts earlier. It starts with letting your kids keep secrets from you. These are the first little bits of independence. It also starts with letting your kid feel hurt, feel excluded at some point, and letting them learn to deal with it, letting your child build some resilience. You know, this is not a thing that comes naturally to most parents. It is not a thing, you know, none of us like to sit back and watch our kid suffer, and so often parents of children who have any sort of medical complexity will say, they have been through so much, I just want to protect them from what I can. There's so much I can't protect them from that I need to protect them when I can. And they still need to be allowed space to grow as an individual, space to learn how to deal with uncomfortable emotions. And they should be able to tell some secrets. I had one patient who was really struggling because you know, she needed an aide, and the aide would never give her enough space for her to be able to gossip with her friends. And her friends didn't want to gossip with the aide sitting right next to her. And so making sure that we are giving our teens the space to be a teen with the supports that they need. I want to talk just a little bit about guardianship and supported decision-making along this line of graduate independence and emphasizing that young adults with Duchenne should be allowed to be young adults with as much independence, albeit physical dependence, but emotional, psychological, spiritual independence as possible. And these are all quotes from one of my favorite websites, the Courageous Parent Network, that pushes fairly strongly this idea, you know, having guardianship lets you make medical decisions for your child, provides uninterrupted access to medical care and supports. Without guardianship, it might be difficult to get medical care for your adult child. To avoid challenges getting access to your child's medical information, it's critical that you take steps to become your child's legal guardian. And those are all really well-intentioned and make sense for some people. Recognizing that Duchenne comes with a wide spectrum of essentially no cognitive impairment to a fair amount in certain people, the majority of patients with Duchenne will be able to communicate their wishes, wants, needs, values. And so I would challenge whether or not this is appropriate for most people with Duchenne muscular dystrophy. And to sort of highlight this, because I know that the parents pursuing guardianship are doing so from a place of caring about their child, wanting to do the best thing they can to support them. I do not mean this judgmentally. I only say this to point out some of the downsides. For the patient, there is this sense that you are taking away some of their rights, because the person who has a guardian is no longer able to vote, is no longer able to get married, because they cannot legally consent. you have taken away their right to legally consent to a relationship. And many in the disability rights movement would say that this is diminishing their personhood. I have not had a single parent tell me that this is why they are doing this. And some will push back and say that is not true. But there are some who are really concerned that when we get a guardian for a patient, that it is removing some of their rights. And so we would look to other ways to maintain that relationship that protective parents want to be able to serve, that good parents want to be able to serve. And for the parent, we don't talk about this at all as we pursue guardianship, but there are downsides too, because now you're accountable to a court. You're accountable to the state because you are not getting your power from your child, you are getting your power from the state. And so you're not beholden to your child, you're beholden to the state for the decisions you're making. And when the time comes that your child is dying, the state is then involved in those decisions too. And that is a step or a bridge too far for many people. And so if we can keep this relationship, this mutually protective relationship within the family, without the state being involved in appointing you, it can actually benefit both parties. And so instead, there are a number of agreements that can be entered into. A healthcare proxy allows the parent to continue to be an appropriate decision maker for the patient. A power of attorney helps you control and help with finances. Representative payee helps you get the benefits from the state for your child. And supported decision-making agreements, these are passing state legislatures across the country. It has passed in New York, and we are still waiting on OPWDD is in charge of putting out the frameworks for enacting this. But the idea is that we all make decisions as a team. Every single person needs some level of support as we make our decisions. If I am making a very significant decision about my health, I'm asking my wife, I'm talking to my parents, and I am getting support in how I'm making that decision. They're giving me input. And the average person with disability is able to make decisions for their own with support. And so supported decision-making agreements are a way to sort of codify who are the people in my life, what do they help me with. Maybe different people help me with different things. This person might help me with my healthcare, this person might help me with my finances. And so for many patients, although there are significant system pressures towards guardianship, I think it is important for us in the medical community to take a step back and say maybe there are things that would meet all the needs of the parent, help support this individual, this young adult as best we can, while maintaining their own personhood in that process. And so just thinking about, down the line, one aspect of palliative care is some anticipatory guidance and laying out people with your condition, you in the future may face decisions. I hope they are a long ways away. Some of those decisions might be feeding tube, non-invasive ventilation, invasive ventilation, gene therapy, clinical trial participation, maybe cardiac transplant. There are things coming down the pike that we'll have to make decisions about. And we don't have to decide those now. And I want to point out just a few considerations before I'm done is, it's important to think about them first, but people adapt in ways we never really anticipate. We learn this in conditions like ALS, where someone gets diagnosed and they may say a certain thing. They may say, I would never want a feeding tube. And when it comes time, they may feel differently. I'm not saying ignore the person who said no, but I'm saying be prepared for change. Be prepared for that individual to feel a little bit differently when push really comes to shove. The disability paradox is this idea that we, as external people, and the data supports that parents to an extent do this as well, underestimate the quality of life of an individual with disability. And so it is really hard for someone else to interpret the quality of life of the person in front of us. Fragility bias says that if someone has a disability, I assume that the same event is more suffering for them. So a hospitalization for an individual with disability just must be worse than a hospitalization for myself. It's not true, it's just that's our bias, is that we assume that there's more suffering associated with that event because they have an underlying disability. And then this idea of therapeutic nihilism is one that we are confronting. And what that means is, because we never tried, we assumed it doesn't work. And so this came up of, well, you know, we never really did invasive ventilation, and so folks died at a certain age, and then we realized, like, oh, we should do that. And now we have learned, and we are starting to see, as more therapies as we are considering, is cardiac transplant something that we should be talking about? Is gene therapy? All of these things are coming up, and we have to be careful that what we're basing this on isn't a assumption based on data when we just didn't try. And so that is all I have. Any questions about what I have said? Great. I managed to not get any messages, I don't think. Oh, no, I did. Thank you. I'm sorry I have to take off after this.
Thank you. Okay, next, saying that correctly, Professor of Neurology and Pediatrics speaking about newborn screening. I do not know. The mouse here just stops working. Okay, here we go. There we go.
So as many of you already know, there has been quite an effort and advocacy about pushing newborn screening for Duchenne muscular dystrophy. And so the question is the case for Duchenne muscular dystrophy newborn screening ready in 2025? And I just want to remind, starting from the criteria, newborn screening is really a population-based screening. So it's really a public health service and program that is based on very precise principles that were actually stated back in 1968 and then revised a little bit later in 2008. And it's important to remember that obviously the society and the way that we think about our health, our access to test and diagnosis has changed dramatically. And so that's something, it's a lens that we need to keep in mind when we think of newborn screening in Duchenne, because I think that some people still feel that maybe the case is not ready. But I think it's a very important discussion to have as a community. You can read the principle here, and I think that we think that Duchenne meets all of these. With perhaps some still discussion about there should be an agreed policy on whom to treat as patient. And the question is not who to treat when, right? Do you treat at 7 days of life or at 2 years old? That's a difference. So, and I think that's still a little bit of the sticky point for newborn screening in Duchenne. But some of the passion and effort to push newborn screening Duchenne really came from the community based on this concept of the very stubborn and chronic diagnostic delay, also referred as a diagnostic odyssey. And with the CDC, the Muscular Dystrophy Surveillance Tracking Research Network, the MDSTARnet, has been a surveillance research project that has been funded by the CDC for decades. And we publish data, and the importance of this is it's really is data that come from population-based surveillance, so not from single clinics, but really from going in different states and abstracting from chart with the authority that public health has, so without consenting, and really getting data that are really reflective of a more broader cohort of people. And when we analyzed people born between 1982 and 2000, we found that the mean age of diagnosis was 4.9, and there was a very major lag of about 2.5 years between the onset of symptoms and the final diagnosis. So a very significant diagnostic delay. We also published the fact that this delay was even greater in Black and Hispanic, so certain subgroups, they even had a larger delay in diagnosis. And then there was a big effort from the CDC, the American Academy of Pediatrics, and many others to really target pediatricians and family doctors to recognize motor signs of muscular dystrophy, a lot of website and development of educational tools also target towards new parents and the public, in the hope that this would really change the needle towards, earlier recognition of symptoms and signs for muscular dystrophy. We did a subsequent publication analysis on a cohort, again from the MD-STAR-NET, where we studied people born later, between 2000 and 2015, and unfortunately, we found the same results. There has been no progress, and the diagnosis is still stuck at about 5 years old. Newborn screening is not really meant to fix diagnostic delay, but as a community, we felt that given that the field is changing so much in terms of new treatment, that this obviously it's a big, big problem. And does delay in diagnosis in Duchenne really matter? And yes, there are a million good reasons why we should not accept this significant delay. And you can read many here, but just as we heard this morning, initiation of a multidisciplinary approach to standard of care and corticosteroids has changed outcomes. And if you get diagnosed at 7 or 8 years old, you really lose a window of opportunity for intervention that can really make a huge difference. And then, of course, now in this modern age, it also the missed opportunity to access newly approved drugs. For example, exon skipping is for all ages. And then to really study the pre-symptomatic stages of Duchenne to see if these new therapeutic approaches could have even a better outcome if they're started earlier. So, and obviously the opportunity to participate in clinical trials directed at very young. So many, many reasons. One of the indispensable things to submit a disease to the RASP is to actually conduct a pilot study. So this was a big accomplishment. This pilot study was actually carried on in New York State based on a now FDA-approved CK-MM kit. So newborn screening for Duchenne is actually a two-tier screening because it's done through CK and then subsequent genetic testing. And so the SPI being started right around when COVID exploded, it was a successful pilot that demonstrated that yes, with the CK-MM kit, we can actually find Duchenne cases, and that's really what's needed to move forward with the proposal for a full review. And so that was done. But the rationale is really that compared with many pilots that were done around the world many years ago, is that now we have a very long list of treatments that are really, all the ones, dystrophin restoration, all the exon skipping currently available are for all ages. The gene therapy that is approved is for 4 years and older, and you can see the ages for the downstream anti-inflammatory, anti-fibrotic agents. So really, a lot of the currently available treatments are for all ages or for very young ages. So a delay in diagnosis, really, it's a big problem. And based on this was the rationale to move our case forward. So the resolve issue, though, about newborn screening is we still don't have a strong case for corticosteroids. Obviously, it's not something that we think about starting in the newborn state. Exon skipping, it's a no-brainer. The sooner the better, and yet it has not been studied in newborns and infants. So some argue that based on the mechanism of action, the sooner you introduce a muscle membrane stabilizer, the better off you're going to be. But that's still some discussion about that. And then because the screening is really based on the CK, you're going to discover and diagnose non-Duchenne dystrophies, right? So you're going to actually identify either elevated CK with no final diagnosis or elevated CK with diseases that really have no treatments, like limb-girdle muscular dystrophy or congenital dystrophy. And that, based on the principle of newborn screening, is an absolute no-no, right? Because you shouldn't really diagnose diseases for which there is no intervention, because the main goal of newborn screening is to actually improve, change the outcome of the infant, right? It's not just diagnose to know. And so these are still sticky points. And then, of course, you really need to be prepared in terms of infrastructure to refer these families and these newborn to centers that can actually deal with the complexity of newborn screening and the nuances of mutation that might not be so easily predictable of phenotypes. So still some issues. But currently, this is where we stand. The nomination package with the pilot, the results of the pilot, with the goal to add DMD to the recommended uniform screening panel was actually submitted in 2022. At first, it didn't go to full review. They needed more information. But eventually, the review was completed, and there was a decision pending. But unfortunately, the Advisory Committee on Heritable Disorders in Newborns and Children was dissolved in April of 25 with the new administration. So there was never a vote because there was no committee anymore. There is no longer a committee. So we're kind of in limbo because basically the decision will be made straight by the HHS secretary, supposedly. So this still, we're a little in a gray area. But the interesting thing is in the United States, although there can be, the RASP can make a recommendation, and usually states agree to implement what's recommended by the RASP. States can also individually go their own way. So there are states like New York State is probably one of the states with the longest list of newborn screening, like 54 or 57, many of whom are not really on the RASP. So what's happening now is that we have 2 states with approved and implemented newborn screening for Duchenne. That's Ohio and Minnesota. They're already screening. States that have been approved for universal screening, but they're not yet screening. Basically, they're waiting for money, for budget, and that is New York, Massachusetts, and Arizona. And then states that are considering passing the legislation and they're pending a vote. That's about 12 states, and then 34 states where there is no activity about Duchenne. So that's where we stand currently, and I think that the case will keep moving forward, but right now we're a little bit of in a limbo for the reason that I just explained. Newborn screening will give us the opportunity to study a subgroup of patients, the 0 to 3, where we have very little natural history. It will also give us the opportunity to study therapeutics very early. So I hope I don't have to convince you what an incredible opportunity this is. And in fact, in Rochester, we got a big grant to actually study exactly this. The newborn screening identified infant from 0 to 3 across many states. So we're really excited about that research starting in the next few weeks, actually. So that's all I have. Any questions?
Thank you so much. And now I'd like to invite, there we go. Your slide deck. Yes, there we go.
Thanks.
There we go. Thank you.
So I'm going to be pinch hitting for Kim Hart, who's one of our research coordinators. Really, I think this underscores the fact that our coordinators know this space better than really anybody else on the team. They work so closely with the sponsors, they work so closely with the families, and they really make it all happen. So just wanted to give a shout out to Kim and Patty Smith, who really keep our whole program going in terms of the clinical trial landscape at University of Rochester. So this is going to be a pretty basic talk for the audience in the room, but hopefully anybody watching this digitally can take something out of this. If they're new to clinical trials or thinking about clinical trials, that's really the intended audience here. So why do we do clinical trials? Really, if we didn't have clinical trials, we wouldn't have any medications, we wouldn't have any treatments. And so a clinical trial is a test of some intervention on some disease. And we've heard from a lot of different companies today about therapeutics that are either approved for Duchenne or in development. And that clinical trial timeframe really spans from early safety testing to showing that the drug is effective and safe long term. So there's a lot that goes into drug development from a preclinical space, proof of concept, but the clinical trial, we really are talking about use in patients. So really without clinical trials, again, we wouldn't have, I'm gonna back up a little bit, we wouldn't have any of the treatments we heard about today. So why participate? Really, this is an opportunity, but it shouldn't be conflated with treatment, right? So I try to make this case to all of our patients who are thinking about participating in a trial. We have therapies that are effective for Duchenne. I think it's fair to say that patients and families still want more. And so they'll look at clinical trials as an opportunity to maybe achieve a treatment that they don't have available commercially. So, that might happen, right? You might be enrolled in a clinical trial that shows great efficacy and ultimately gets approved. So it's an opportunity to really enter at that early phase. But I think more importantly, we're learning, right? And this learning doesn't happen without participation in trials. So I try to frame it when I'm speaking to a family who's considering participating in research in this capacity. We don't get the data unless you're involved. The third point here is interesting. So with clinical trials, you do have a lot of close monitoring. So typically visits will happen, sometimes every week, sometimes every month, depending on what the therapeutic we're talking about requires. And there's some interesting evidence that even participating in placebo arm of a clinical trial, those patients tend to do better. So I do think that there's a care delivery component that we can make. I mean, you're seeing the physical therapist, you're checking in regularly with your physician, and if there's an issue, you get immediately sent to the right people to deal with that issue. So I do think that there are some benefits that we don't necessarily advertise because we don't want to coerce people, but that is a true effect that's been studied. So risks and considerations. So some of these are obvious, but I think they are worth reviewing. So again, this is experimental. We're talking about a research stage. If we're talking about an intervention in a clinical trial, we don't know sometimes what the risks are. Sometimes if a therapeutic is within the same class, we can kind of glean, okay, other gene therapies have shown this or that. Other exon skipping agents, PMOs, we've seen this or that. But a lot of times we're talking about a drug that is unknown, and sometimes we don't know what the potential risks or side effects are. Time commitment. So this is huge. This is not an easy ask of patients or families. This takes a lot of full day blocks sometimes. If you're going to see the coordinator, the physician, the nurse, there's an infusion maybe, there's a blood draw, there's a PT assessment. So this is a big time commitment. And that obviously has impact on things like school and work. So it's something that everybody needs to consider. And then the other thing is some of these centers, many of the centers in the Duchenne space, they're not necessarily down the road. So a lot of families will need to travel, which can present its own hardship. And the third thing is placebo group. So we've heard a little bit about different clinical trials that are taking place in Duchenne. Not all of these have a placebo arm, but placebo just means that you're essentially not receiving treatment. So it's a way that we can do a comparison and say that the drug we're talking about actually has some efficacy. There are other ways to do this. So we saw some data that use natural history comparators, and I think that's an intriguing way to approach a comparison group. Natural history comparators have their own issues because a lot of the times that data is kind of historic, and we don't have a comparison against modern day standard of care. So a lot of smart people are working on that issue and trying to sort of do this in silico modeling to present a more accurate comparator group for some of these interventions. So how do we participate in clinical trials? So I think the first place to start, there's a really nice website. It was up before the government shutdown. It's probably still up, hopefully is. Clinicaltrials.gov. If you type in Duchenne muscular dystrophy or Becker muscular dystrophy, you'll probably see more trials than you knew existed relative to that disease. And not all of these trials is going to be one that you are even eligible to participate in, but it will give you a sense of the landscape, and many of them will be something that you can partake in. I'll say too that this website doesn't just include interventional trials that look at the effect of a potential therapeutic. They're including things like natural history studies or maybe biomarker discovery. So clinicaltrials.gov is really a nice gateway to broader research landscape in Duchenne, not just for drug trials. Other resources here, patient foundation websites. So Jett Foundation, I'm sure, has some resources available. Other Duchenne patient foundations certainly do. And then ask your physician. So if you don't feel like you're at a center where you're getting that information about what potential research opportunities there might be, it's always okay to see if you can get referred to a center that's doing some of this work, even if that's not your standard touch point for receiving care. I think it's good to have that check-in with some of the larger centers that are actually doing the research, just to stay in touch with what's happening. So each trial has specific inclusions and exclusion criteria. So what that means is, if we're thinking about a new drug in Duchenne, that drug might not be meant for every patient with Duchenne, or we really need to discover if that drug is having an effect. And it can be hard to compare, let's say, a 3-year-old with an 18-year-old with the same disease. So there might be age criteria that you have to fall in between. There might be kind of functional criteria if we're talking about ambulation. So it's important to think about what are the inclusions and what are the things that might exclude you from a trial. Unfortunately, trials can't be all things to all people, just based on how we have to do the analysis and discover if a drug is actually effective. Finally, it's important to go through the consent form, ask lots of questions. This comes up when, kind of later stage when you're thinking about participating in a trial. Again, it's not a decision to take lightly, and no question is a bad one, so ask lots. I think that's all I have. Thanks for your attention.
From Bridgewater, Massachusetts. I'm 30 years old and I have Duchenne muscular dystrophy. I've learned with Duchenne's is to embrace life's challenges and turn them into opportunities. As a driven entrepreneur and managing living independently and playing wheelchair soccer for Team USA, I learned to take disability and turn it into an ability.
Hi everyone, I'm Perlita Haynes, and I live in a small town in central PA, Lebanon, Pennsylvania. It's very close to Hershey, and I'm a mom and a wife, and my husband and I have 3 children. They're young adults now. Luke is 25, Lance is 23, and our Levi is 18, and he's our son that has Duchenne. And we're really proud that he's graduating high school in a few weeks, so he's a graduating senior. So we really don't know where that time went. And Levi was diagnosed when he was 2, so we were really early diagnosis, which we're happy about because he was able to get some therapies and things started much sooner, as some of our boys get diagnosed a little bit later. But Levi sees doctors at Penn State Hershey, as they are a center of excellence for Duchenne, and he has been part of a few clinical trials that really didn't show a lot of promise. He started with the Adalurin trial, but now he is on an FDA-approved drug called Dubizet. So we're just plugging away with that medicine. But Levi is a happy kid. He is very active at school. He's part of He's the manager of almost every team, you know, the baseball team, the football team. His school really does love him, and it's going to be an interesting transition for next year. He's going to do online community college and study history. So, and if I had to give some words of encouragement to a younger family that maybe is just starting this journey, is lean in on us, lean in on those of us that have gone down this path. It's not all doom and gloom. It is, you will find joy in your life, I promise you. And we are here to help you at any time. We are here to really help and guide because we know where you've been. We know where your heart is. So we are happy to help you and your beautiful boys. And I hope you're all having a great time in Alabama. See you later. Bye-bye.
Hey everyone, my name is Ray. Our kiddo is Jace, and he's 11 years old. He was diagnosed 2 years ago with DMD, and he was actually diagnosed 2 years before that with dyspraxia, ADHD, autism, all these things. And they said to make sure you work his body out, and that's exactly what we did until we found out the real diagnosis. And of course, as parents, you beat yourself up, and you know, the would've, could've, should've moments that you had. I would say the first year diagnosis was a blur for me. And I know your family and friends, they care about you, and of course they feel sad and bad, but no one really understands the roller coaster of emotions that you have when your son is diagnosed with DMD. So finding the outlet like I did with Jett Foundation and all the DMD moms that I've met, it makes you feel like you have someone in your corner, someone who knows exactly how you're feeling, and it's your tribe. So I'm grateful for the Jett Foundation, and I'm grateful for all the DMD moms that I've met, because who knows how my state of mind would be right now, because for a moment there I was lost. Getting all teary-eyed. Anywho, just want to let you know you're not alone, and we're here for you. You need anything, this is what we're here for. And I just want to make sure that I am here for the people who felt like I did 2 years ago. So thank you, and hope to see y'all ladies soon.
Hi, my name's Paul Heaton. I'm from Warden, Montana. I have a son named Grant. He's 10 years old, going to be 11 here in about a month. He has Duchenne muscular dystrophy, and this little video is to tell you that you're not alone. If you're just diagnosed or in the process of after being diagnosed and trying to figure everything out, the one thing took me a while to learn is there's other people out there like you. Your job as a parent is still the same. Your job is to do the best for your son, raise a good person, teach him wrong from right. Hang on to that and do the best you can. It's what the rest of us are doing and have been doing. Grant's been diagnosed now for 8 years. We started doing some fundraising through our Calves to Cure DMD all-class cattle sale. That's helped a bunch, but to be able to talk about what Duchenne is and how it affects Grant and what we can do to help other kids, that's one way to go. You don't have to do that. Do whatever makes you comfortable. Most importantly, love your son. You're not alone. If you need to, reach out to me through the Jett Foundation, and I'll sure visit with you. Hope you can hang in there and do the best you can. Talk to you later. Bye.
Hi, my name is George Chapetta. I'm 30 years old. I was diagnosed with Duchenne muscular dystrophy at birth. I'm from Bridgewater, Massachusetts, known as the City of Champions. My journey with Duchenne muscular dystrophy has been great so far, but there's been some ups and downs. But I live my life to the fullest. I represent the Team USA. I am founder of Disability.Daily on Instagram. I live independently. I own a dog. And what I want to say is for the younger adults and younger kids with Duchenne muscular dystrophy, if you put your mind to anything, you can accomplish it, even if there's some obstacles involved. You just got to remember, you're not alone.
When our first son was diagnosed with Duchenne, I completely froze. I felt like it broke me. I didn't know what to do. I didn't know who to talk to. And then we find out our second son has it too. Those first 3 days were terrifying. The fear, the Googling, the worst case scenarios, none of it really helped. But what did help was finding other families. People who lived it, who didn't just understand the diagnosis, but actually understood the feelings that came with it. And that's when everything started to shift for my family. We never expected Duchenne to be part of our family. Nobody does. But what I have learned is, yes, this diagnosis can rock your world, but can also bring you into a community full of the strongest, kindest people you'll ever meet. We're families who love big, we show up and find meaning even in the hardest times. If you're just starting out, if this is still new, please know this, you're not alone. There's a whole community walking this road too. And while it's not easy, you do not have to walk it by yourself. You've got this and we're with you and you're not alone. If you ever just want to hear real stories or feel less alone, we share our journey on YouTube at the Bafis Family. Please come find us because we would love to walk with you in your journey.